Hi everyone, welcome to quarter 3 Safe Everyday event. Really pleased to welcome you all here. I've got a really good attendance, so thank you all for coming in person. I think it makes the speakers' jobs a lot nicer when there's people in the room. And hi to all of you that are online as well. My name's Tammy, I'm from the Quality and Patient Safety team. And I'd like to welcome you today. We've got 3 really good presentations from different areas. So the first one, we've got a presentation on the rollout of Restore 2 by Helen and Fiona, the PDLs, one from CUTE, one from Adult Disability Service. And then we've got some presentations from Older Adult Mental Health and the LD team. But I'll just welcome Fiona and Helen. Thank you.
Hello everybody. Nice big room, this is good. Bear with us. I haven't tried this technology before, so we'll just see whether I can actually make it work. My name's Fiona Hambleton-Relf. I am Practice Development Lead for the Adult Disability Services, which is Learning Disabilities and Autism. This is my colleague Helen.
Hi, my name is Helen. I'm Practice Development Lead for Acute Services.
And we are here today just to tell you a little bit about a piece of work that we've done in relation to introducing the Restore 2 tool to Adult Disability Services particularly. Restore 2 is a tool that incorporates the News 2 tool, which some of you may be familiar with. Hopefully most people in Adult Disability Services now are familiar with it. Initially, the News 2 tool was created by the Royal College of Physicians in 2012. It was thinking about the deterioration in health and how to make a good evidenced record of that with people who were acutely unwell across the National Health Service. The News 2 tool is a 2017 revised version of this. It incorporates some more evidence-based elements because we should be doing all our practice from an evidence-informed basis. And it refined the guidance as well to make sure that people were using the tool in the correct way. It was formally adopted in 2017, endorsed for hospitals and for other settings where that record became a really useful measure of people's health state. It's been endorsed for use in acute and in ambulance situations and settings, and currently 100% of ambulance trusts in the UK and 76% of health acute trusts in the UK are using the News 2 tool. So you can see it's been very well adopted and has a very good track record. It's been going now for 14 years altogether, and 8 years in its current state. Restore 2 is an additional part that is used alongside the News 2 tool in particular situations. It was developed to identify physical deterioration and how to escalate where people were becoming ill, and particularly to be used in residential homes. And it's also used in community settings as well, which is where Adult Disability Services comes in and became interested in it. It evidences the soft signs of health deterioration. So where News 2 is all about the numbers, Restore 2 is all about those softer signs that care staff can identify, but it's harder to put your finger on. When somebody's just not quite right, they're not quite well, there's just something, they're off today and I can't put my finger on it. It was a patient initiative, safety initiative to support staff working in non-hospital environments, monitor, record the health status. It evidences changes, generating a shared language and a shared understanding. And that's a really important part of it, is that shared language. Care language is very often different from health language. And whilst you may be saying the same thing and you may be working towards the same goal, if you're not using the same language, then a lot of miscommunication can happen. and things can get missed. It includes the SBARD tool, which you'll all be familiar with through use of our incident reporting, with a framework for sharing the evidence and to escalate. A lot of frameworks in there, aren't there? So this is the image. This is the Restore 2 part of it, which some of you may know, some of you may not. It turned out the staff were very good at recognising those soft signs. They're recognising when people are unwell. It was difficult to evidence. Staff saw soft signs, professional responded to the evidence and to the numbers, to the measurable signs. And that structured approach to communication became really important. Across adult disability services, we were having numerous incidents where people were being reported as their health was deteriorating, and emergency services were being called, or GP services were being called, other professionals were being contacted, but it was difficult to express to the other professionals the need for intervention, because the soft signs didn't mean as much to the GPs, to the emergency professionals, as it did to the care staff who had that kind of gut feeling about people's health state. And staff felt vulnerable in themselves, but were most concerned for the needs of the person in their care. And the use of Restore 2 came about because it was suggested by the quality and improvement and training manager, Claire, who said, have you had a look at this? So we did, and actually it's a really useful tool. Me? Yeah. So in order to implement it, to bring it into adult disability services, Helen and I got together, we sat down, we had a look at the existing training, which was about physiological measurements training. And we worked through it to look at what worked, what made sense for community services, for residential services, as well as for acute. And there were differences, of course there were differences, but there were a lot of similarities. And we were able to bring that together and generate a training tool that actually worked across, that you could include bits or leave bits out depending on who you were training at the time, depending on who was in the audience. We've delivered the session several times now. We started out focusing on the registered staff, and particularly the nurses across adult disability services, so they could then go away and they could assess the competence of their staff who were coming on this training. The focus initially was on the registered staff, the management team, the leadership team, because they would then be able to implement it across their services. And the idea was that we will get a baseline for all the different people who we support across our service, which then makes it easier to evidence when somebody's health is changing, because we can say how their baseline measurements have altered. We've trained 47 staff altogether from adult disability services, which may not sound like a lot, but on average, it's about 3 to 4 staff per individual service, which means that that's quite a good spread, I think, to begin with, and it's quite a good way of ensuring we've got enough people to start to implement it and make it effective. And the first evidence that we had that it was having an impact was when we got through incident reports that started mentioning the News 2 tool and people's news scores. And the fact that they had been used when talking to emergency services in order to escalate the situation for the individual. We've also joined and sat down with the community, adult community practice development, who's here on the front row, to develop a training package where we looked at how it might eventually be rolled out across adult community, or sections of adult community services, certainly, and whether or not it would be helpful and useful to them. And that would involve community, it would involve residential, it would involve domiciliary type services, and training in all those different elements. I'm going to hand you over now to Helen, who is going to tell you a little bit more.
So I think you've introduced most of the News 2, which is helpful. Can I just ask in the room, who was pre-2012 and saw the implementation of the News 2 scoring system? So any feedback about that? I'm not, no offence, because people are saying, I don't want to show my age. I actually was as well. So any feedback about that? Any feedback about our early detection and recognition of patients who have deteriorated?
So yeah, I remember it well. We had the medical early warning score, and there was, with the score, you didn't really know what to do with it. You didn't.
You scored it,
just,
and then
it was scored, and then you kind of, it didn't mean anything.
Yeah.
Whereas the News 2 definitely did.
Okay. So obviously, being fairly new to the role, having been in a community setting, I found it really interesting linking up my acute experience and community experience, and hearing people's sort of understanding of the tool and how it's used in practice, because that's what really matters, isn't it? It's well researched that the early detection and appropriate intervention from use of an early warning score helps in patient outcome. So that's well researched. The second most important thing I found was the use of the common language between us all. So as Fiona mentioned, ambulances are using it, as are hospitals. But for example, some of our more remote areas that would need some help and need to escalate care needs to someone, found themselves feeling quite vulnerable about how they communicated that. So, for example, if you have predominantly worked in social care, phoning an ambulance and saying they've got a respiratory rate of 12 was unnerving, because it's not terminology they'd used before. So by teaching them the news scale, which I was hoping would be behind me, we can give an aggregate score of all of those vital signs accumulated into a total score, and when we communicate the score, which is not so nerve-wracking, because we're saying a score of 5, for example, it would trigger an appropriate response. So it takes the pressure off the health professional to indicate exactly what we're trying to communicate, if that makes sense. Mm-hmm. So the tool looks complicated, even though it isn't there, but it's a really good numerical and visual aid for our communication. So if we use a traffic light system, we know that green is good, white is good, green is acceptable, and as we go to amber and red, we know that we're getting into trouble. They are our early warning signs. So it takes the pressure off people having to interpret what those scores are, because obviously we know that vital signs are variable between each person. I think you've mentioned all of the things I was going to say. In 2017, the news score was revised, and that's when it became the News 2 scale. And they added 3 very important things. One of them was safety in prescribing oxygen. So some of the cases we were reading was around oxygen just being misunderstood. If somebody was breathless, we just applied oxygen, and we all know now that that's detrimental, can be detrimental. So we don't want over prescribing or applying of oxygen. The other one was about new confusion. So new confusion is a really strong indication that somebody isn't well. But that's often really difficult to understand, isn't it? Especially in certain groups of people who, may have confusion anyway. So it's that new confusion. And the other one is that they made the aggregate score of 5 being our trigger. So the whole point of it is to track and then trigger appropriate responses. Who should use it? Everybody. Anyone who's using and understands physiological measurements, who understands vital signs. So it doesn't just have to be for registered staff, and like we know, we have areas without registered staff, and very often it's the unregistered staff who are hands-on, who are there, who are present, who know their patients or residents or people really, really well, and so they can tell if something isn't quite right. So there seemed little doubt that the implementation of News 2 across ADS would support recognition of deterioration faster and give people confidence to escalate their concerns, and therefore we hope would survive acute illness.
Thanks very much. Thanks. Yeah, any questions for Helen and Fiona or Claire?
Hopefully, Elizabeth, could you just give like an example of what is in Restore 2 that isn't in News? So you talk about soft science, what sort of things might it be asking you about?
So, and it's a really good question, because when I teach News 2 is, you know, it's quite self-explanatory. There's a box with numbers and you put it in the right box, so you know you can fill it out. What I always say is clinical judgment comes in first. So actually the Restore 2 is as helpful. It just allows us to look at the person. So even though we might see, say, a respiratory rate, somebody's breathing is very, very fast, do we need to put that into a scoring system to see that, or do we see it because we can see it? Are we looking at our people? Are we looking at, you know, the people that are in our care? So the Restore is looking at the person as an individual, what is different for them, what is new, whereas the News 2 score is a bit more mathematical, and you know, you can't really deviate from putting your responses into the right boxes.
And I think as well is because some people say with a learning difficulty, they might not tolerate having their obs done, so they might not tolerate you being able to get those numbers. So knowing that person and knowing what their baseline is, like you said, is really important, because you can see that deterioration.
Yeah, and the joint working, I've learned so much, because I think I've taken for granted in acute care that we just do things quite, you know, habitually, whereas there's sometimes more thought needed to be taken in what we are doing to people, and the challenges we face. And learning about your PBS talk that you gave us was also interesting, because there is some work that we could be doing before we start doing observations. You know, we could be, I don't know it like you, but we could be working very much with people to help their understanding of taking a blood pressure, which for some of us is just a routine thing that we do.
I think one of the real benefits as well is that in developing a baseline for people, we're also working towards desensitising some folks who find it really traumatic and difficult to be in like a hospital situation, or a GP, having blood pressure, having even as simple as having the clip on the finger to do SATs and things like that. And we can actually work with people over the longer term, so that should there be a crisis, should there be an acute situation for somebody, they're not going to be as fearful, they're not going to be as anxious about any intervention that we might need to escalate to them.
But it also lends itself to not having diagnostic overshadowing.
Yeah, absolutely.
And it lends itself to appropriate diagnosis for people with learning disability and autism.
Yeah, very much so. And one of the really useful parts of the Restore 2 bit that adds into News 2 is the fact that it has the SBARD page on the back, where you can make notes about what you need to say, and it gives you a script. And staff who may be feeling, you know, anxious about ringing 999 or the GP, they actually have a script there to say, hello, my name is ... I'm ringing about ... date of birth ... this is what I've seen, and so on, and they can actually escalate it with much more confidence.
It's quite a nerve-wracking thing, isn't it?
I was just going to say, I think as much as you can structure a conversation, I personally think the human factors that come into that, when you're faced with an emergency or somebody who you think is, you know, poorly, that kind of all goes out the window. So if you at least have a confident way of saying they've got a score of 5, you know you'll be heard, you know the person who's on the other end of the phone is listening to you, rather than having to really worry about what you're saying and wasting time potentially.
Have you tried using it with the GPs, or are the GPs on board? Because I know in the past with News 2, they weren't keen, but it was a long
No, not
time
yet.
ago.
Yeah. We have used it on 1 or 2 occasions, yes. Yeah, and it has resulted in a GP coming out to do a visit where, you know, based on the kind of softer signs,
Yeah.
oh, looks a bit pale, is a bit clammy today, you know, not eating properly, those sorts of vague signs may not have generated the same sort of urgency or the same sort of impact in
That you
terms of generating an idea of the seriousness of somebody's deterioration.
And the news score is quite prescriptive about the aggregate scores and what you do with them. So obviously it works really well for us in acute because we have all the processes around it. But certainly in community, you know, that's a bit different. So we really encourage not just the accurate completion of the news 2, but the to just be a little bit deeper than that, and that actually goes back to the restore. What exactly is it you're trying to say? So that you get your message heard.
Yeah.
And it's the story around it, isn't it?
Yeah.
Just rather than just the number.
Yeah. And with an individual escalation plan. So once you've generated a baseline for somebody, it may well be that their baseline is not, you know, it generates a score in and of itself. It's not all zeros. But if you know that that's somebody's baseline, then you've got more evidence to say when it's different, and you can generate an individual escalation plan that says, okay, their score is 3 normally, will, you know, once it goes above that, whereas with somebody else you might be thinking, wow, it's reached 3, that we really need to do something now.
Has anyone used the Restore 2? Restore tool or in the setting?
I was actually going to say, I wonder if it would work with patients with dementia.
Yeah, definitely.
Yeah.
You know, like even on the acute wards,
Yeah.
you know, that it'd be amazing.
Yeah.
Yeah, absolutely.
And
Alongside the news.
You kind of do it anyway, but it just
Well, of course
allows
you
you to
do, but
remember all
yeah.
the bits that might
Yeah.
be a bit odd, or
Would
a
it be-
little bit different to
It
normal.
formalises it, doesn't it? It formalises that gut feeling.
Yeah.
And often it's the gut feeling that would then lead you to do a news 2.
Yeah, because sometimes you can say, actually, all the numbers look right, but there's something not wrong.
For the surveillance
Right,
observations, so in
yeah.
hospital we have to do them 12 hourly if people are, you know, just obviously a lot more if they're sicker, but if they scored a 0, for example, we would just have to do it 12 hourly, just as like surveillance. So obviously we're doing sets of observations, and in outpatient departments and things like that, you're not going to escalate in the same way, but for you to say, for example, you're somewhere like you might do observations every week, just once a week, or once every 2 weeks,
Or once a month.
or once a month even. So you can see it's not being used in the same way as we would use it in acute, but either way you've got a really decent baseline, and you can still see the difference in whether that's improved or deteriorated over time.
Going back to what Joe, oh sorry.
So I have a couple of questions about that.
Yeah.
So where do you record these ones? On track?
So we don't record on track
So
at the
how
moment.
I work in dementia.
Yeah.
So how well, because you said that I see that it's coming incident reports. I'm not going to see all the incident reports.
No, so the incident report that was entered was about a situation in community setting.
Yeah.
And what they were saying was they felt more confident in recognising deterioration from using the News 2 scale because of the training they'd had, and also the confidence in how they asserted what they were trying to say.
But at the moment, it's not sort of transferable there. is it?
No,
Yeah.
no. But
It's just been
that's the
documented in
essence.
clinical notes.
Yeah.
really.
The second thing, obviously, I noted that everywhere it says news to restore was trademarked, and
Yeah.
we have brought the rights to that.
It's a national.
It's a national
thing.
one, don't worry, we're not
No.
making any copyright.
The only reason is like MMSE which we used to use was open research before,
Yeah,
and
this
it's
is
suddenly became trademarked,
open.
and now we can't use it.
Right.
So that's the reason I asked.
This was at one point. It was when they had sequins. It was sequined by for NHS England. For everyone had to use it.
Had to, yeah.
So it's there's no problem
Yeah.
with that. Going back to what Joe was saying, I went to a deteriorating patient conference once, and they had I don't know if it was News 2 or the Restore tool, but one of the kitchen ladies had detected that someone had deteriorated, and so obviously no health, like no clinical background, but they had been on duty for the last 2 weeks, and they've seen that patient and they thought, oh, they look really different, and really they can't do this today, they can't pick up the knife and fork and eat, and yesterday they were eating fine, so they flagged it up, and they won, I think they had like Sepsis Stars Award or something like that, and they won that for that month, so it's really, I think you could use it in all sorts of different ways.
For the people in the room who are shift leads or coordinators or whatever, for me it highlighted the importance of listening to the people that are reporting things to you, how small or trivial it may seem, because somebody who can't open their eyes today might just be said to you, you know, in passing, but now we might be a bit more alert to that and go and have a look. Well, shouldn't.
Any more questions for Helen and Fiona? Well, thanks very much. We'll just have a couple of minutes if you want to grab a quick cup of tea, and then we'll start the next presentation. Thanks. So I'm just going to introduce session 2. So it's a session called Stomp, and the LD team will talk to you about that. So we've got William Howie, consultant psychiatrist, Shelley Taylor, specialist community learning disability nurse, and Jess Murdoch, who's a student learning disability nurse. Thanks.
Hello everyone, welcome to our presentation on Stomp. I'm Jess.
I'm Shelley Taylor.
And I'm William.
So Stomp is stopping the over-medication of people with learning disabilities and or autism. Our aim today is to educate healthcare professionals about Stomp who work with adults with learning disabilities or autism. The learning outcomes is to be able to describe what Stomp is, to know the statistics that have influenced Stomp, and to understand the evidence-based practice supported by Stomp. Be able to raise awareness to others and to know what to consider when initiating Stomp. So first of all, what is Stomp? Stomp is a campaign that was response to the NHS for the Winterbourne View investigation 2016. It is also part of the NHS long-term plan. It reviews the use of psychotropic medications with the aim of reducing or discontinuing the medication that is not required. It aims to ensure psychotropic medications are only used when necessary, at the right dose, and for the shortest time. Stomp is not anti-medication. It aims to improve quality of life, reduce early mortality, and to stop using psychotropic medications to manage behaviour. STAMP is also a similar project for young people which is supporting treatment and appropriate medications in paediatrics. So the findings. So this was done in 2015. So 30 to 35,000 people with a learning disability or autism were prescribed psychotics with no appropriate reasoning. They had no diagnosis of a mental health issue. It was far too long with minimal reviews and with inappropriate dosages. It presented side effects including sedation, premature death, and weight gain. To manage behaviours that challenge, which actually is a chemical restraint. The letter in 2020 concluded that a quarter of people who died were on antipsychotics medication and 8% were taking 2 or more. So this influenced NICE guidelines. So the NG11 is Challenging Behaviour and Learning Disabilities, Prevention and Interventions for People with Learning Disabilities for Behaviour that Challenges. It states only to use antipsychotics to manage behaviour that challenges if psychological interventions have not been successful, to treat the threat to the individual or others is extreme, and it is to be used along non-pharmacological interventions as well. I'm going to pass over to Shelley. There you go.
Right, so the Guernsey Learning Disability Framework doesn't actually discuss Stomp, but there are themes. So if you're looking at health, you're looking at annual health checks, you're looking at the 3 monthly medication reviews that take place, and you're looking at the reasonable adjustments that should take place within them environments like your surgeries and things like that. Your annual reviews, medication reviews, it's a really good thing over here, but it doesn't I don't think it's taken seriously. Continuously you'll see people in our community with learning disability and autism that are on antipsychotropic medication for years on end, it's never changed. We've come across a couple of cases where medication we thought was prescribed for epilepsy was actually prescribed because someone's behaviour, and no intervention was ever discussed or taken place. and you're talking about 10, 11 years. If you look at UK, you can go back 10, 20, 30, 40 and 50 years. So one of the other areas is the knowledge and skills of paid staff. So when you are going, you have got your staff trained up, and they should be trained up in the PBS, in communication. They should be accessing clinics such as your SALT, such as your PBS clinics, to get that further education of how we're best to support people. Because the majority of the time when people are presenting with a challenging behaviour, they're trying to tell you something. You need to understand what that is. It's not that they're being difficult. So it's really important that your staff have a really good knowledge of the people they're working with. The care documents need to be to a high standard so people understand how to support. That person needs to be involved in them care documentations and the development, the families, people that know them well. You need the expert knowledge of your PBS clinics, of your speech and language, OT, physio, learning disability nurses. We can all provide expertise and deliver highest delivery care and excellence. We need to be advocating. You'll see our team, the Community Learning Disability and Autism team and the ADS team will advocate and argue and stand up for the people with learning disability and autism time and time again, because medication has not been reviewed. It's been accepted that it's because of someone's challenging behaviour. We're not questioning what the rationale is behind it. So it aligns, the learning disability framework aligns with the STUMP in terms of that it's person-centred, it's about health equality, equity, and it's about staff training as well. Local STUMP pathways, so the limitations that are noted are poor engagement from other agencies. That's looking at your GP surgeries, MSG, the hospital, but it's not about you not doing it, it's because you don't know about the STUMP. Maybe we're not putting that out there enough, we're not selling it enough. Increased anxiety of families and carers. Your families and your carers, they go to the GP, they go to the specialist, what that specialist and what that GP says is believed, it's paramount. So if you're coming along as I've come along, or as we've come along and said, well actually we need to look at this medication, well no, this needs to be taken, GP says, this specialist needs to be, this specialist says, but it needs reviewing and we're challenging it. Workload, we all have big workloads, don't we? We often miss things. Communication between professionals, like I've just said, it might be that we're not selling this enough, it's not out there enough. But the positives of the local pathway is side effects are reduced, less outpatient appointments, awareness across services is increased, and highlighted the importance of annual health check. Okay. It's your turn.
Thank you. Which is the button for?
Oh, that's for forward and that's for back.
This for?
Yeah.
So I always think a case is quite helpful for concentrating the mind. So June is a 72-year-old lady who, when I started, was on olanzapine, carbamazepine, clonazepam and naltrexone. And there'd been no concerns. But of course, these drugs aren't usually prescribed by GPs, and so the GP had presumably assumed that this is the medication that the person was supposed to be on. We had difficulty finding the old notes, so it was difficult to work out why they'd been originally prescribed, but in the absence of evidence of reason to continue them, they were gradually reduced and discontinued. And the quality of life has improved and the behaviours have not returned. So this is what can be achieved. I would imagine that a few people in the room, when we've been saying that it's about using the right medication for the right purpose, would say, well, don't we do that every day anyway? But the reality is that after an acute episode of care, people are often sent back to, their care is transferred to primary care, who may have very little idea of why the person is on the medication in the first place and about the process of review. And so the medication can be repeated for decades without anybody paying it close attention. So it's worth repeating again that it's not anti-medication, it's about the right medication for the right purpose and making sure we're thinking about the right dose. One of the things that I say is that if somebody is referred to me and not to the rest of the team for an assessment of their needs in a holistic, multidisciplinary way, then it's because they want medication rather than because they want to find out what's going on for this person and find a solution. So if I'm the first person to see the person, I'm being set up because my only tool is a prescription pad. So it's about multidisciplinary, multi-agency working. And these medications are not without their problems. So those who've been familiar with developments in the UK will be aware of the Oliver McGowan training. And Oliver McGowan died from a rare complication associated with the use of antipsychotic medication, neuroleptic malignant syndrome. But things like metabolic syndrome kill people. They contribute to poor quality of life and cause serious harm. So, from my perspective, it's firstly about picking up these people that have been on medication for a long time and we don't know why they're taking these medications, and thinking about a biopsychosocial-environmental approach involving the whole range of specialities. We often talk about positive behaviour support as though it's some mysterious thing that the positive behaviour supports team do. It is simply a framework for thinking about how a person understands the world, how they communicate their needs and what those needs are. And everybody can and I think should contribute to that. So, yes, one of the big problems that we deal with is that if the patient isn't complaining, they're invisible. In stretched services, if you refer somebody who doesn't have a problem, the referral is likely to be rejected because it doesn't meet a threshold. Why are we seeing this person if there isn't a problem? These medications are a problem, and the reason we're talking to you all today is to get the message out there is that we want to know about these people in order that we can hopefully improve their care and improve their quality of life. Thank you very much.
Have you got any questions for the team? Back there.
It's not so much a question, but it was raised in the presentation, but there's a lot of people on antipsychotics that have been monitored for side effects. Something I've really picked up on while I've been here in Guernsey. And people can have some disastrous side effects, but it's not picked up on. Or, for example, if someone's hypersalivating, they'll think, oh, it's just because of a learning disability. But if you look deeper, it'll actually be because of side effects of antipsychotics. Now, if they're not on medication or they're on too high a dose, it's just something to keep an eye out for as well. I don't know what scoring tools are used to monitor side effects here, but something to look at.
Yes, thank you. That's a very good point. For the people on the STOMP pathway, we routinely use the LUNSAs for measuring the side effects of medication, but there are all sorts of other side effects that I think it's worth looking out for, things like weight gain, blood tests for lipids, etc.
Jo, you have a question?
Yeah, I know your talk is mainly about Stomp, but you mentioned Stamp. Is that in Guernsey yet? Are we looking at, or do you have any information? Just always fascinated that there's obviously the Stamp as well as Stomp. Yeah.
I'm assuming that would come from more the paediatric side. I believe it is part, and I think, have you had any Stamp involvement?
No.
just
But
adults.
essentially, it's not rocket science. It's surprisingly difficult because of the sort of perverse incentives. But Stamp is the same as Stomp. It's just thinking about really why is this medication being prescribed? Are there alternatives that might work better? Is this amount needed? And so it's a different name for the same process. And you kind of think that everybody would be.
I just wondered if we don't currently have Stamp, are we seeing children transitioning to adult services over medicated, or are we picking up any trends or
There is
anything?
historically, we have had an individual historically where the medication for epilepsy has not been reviewed in 17 years, and they're on medication, and and what you've got with, so we put people.
That tends to be at the other end of life. The oldest I think I've come across so far is a lady in her 90s who was started on epilepsy medication for a seizure during pregnancy and was still on phenytoin 60 years later.
Yeah.
She didn't have a learning disability.
I mean,
So this is just as applicable for people who don't have learning
What your
disabilities.
doctor says.
So, as an on-call psychiatrist, sometimes, most of the time I come across people with learning disabilities, will be when they come to A&E at 2 in the morning on a Sunday. I'm expected to do something. A&E saying, we have got 4 hours to do this. You cannot wait for somebody coming from the disability on Monday. The only thing I can do at that time is either admit them to a mental health ward or give them medication, which is that. So that time my hands are tied, isn't it?
I think it's then following it up. So once that medication has been used.
But the on-call doesn't follow learning disability patients. Because I'm going to do my day job, which is in dementia. So I'm not going to follow them up afterwards.
There's a gap in the
The
system.
emergency department is one of the most unsafe places you can be.
But that's
People
what
think-
that's
people
what they
think-
are.
Yeah, people think you come into hospital and it's a safe place, but actually all sorts of stuff goes on in emergency departments. You can only do your best, but what I would ask is if there is, and this is why we're talking about it, because we want systems in place so that if you see somebody and start them on medication, you probably only give them a week's supply of medication. We get to find out about it and we can call in the PBS team to have a look at it. The staff can arrange for the person to go to their GP and have a health check if there are physical health problems, and so it just gets the ball rolling. So
You should have most. I mean, what our service users, if you've got someone that's gone to ED, if they're not in touch, not in touch with the adult disability service, you can always contact the duty, the community learning disability service.
At any time.
Say 95.
But you can send an email, because I mean this.
Yeah.
You don't want a response at 2 o'clock in the morning. You just want to know that the next week, you want to know that the next week somebody will pick it
You're
up.
looking at the aftercare. You prescribe something, so that person that needs looking at afterwards, and that needs aftercare. Is it something that needs to go to? Is it something that needs overseen by the adult disability services? Is it something we can do, or that we can offer support with? So that person's not prescribed that medication lifelong, and it's never followed up, and it's only an acute episode.
A short benzo, wouldn't it? We wouldn't. It's very infrequent that it'd be commencing an antipsychotic or anything like that.
But you'd also be looking at why that person's gone to the ED. You'd be looking at their physical
Because
health
they come in with
signs
their
and
carers.
things like that.
The carers have exhausted everything else.
Yeah.
So,
But yes, the follow-up
But
would be.
We are working to try and make sure that happens less often, because sometimes inevitably that happens, but quite often it happens as a result of a failure of care. So things that should have been picked up weeks or months before haven't been followed. Can be something acute, a toothache or something that just suddenly appears. But quite often you'll find that if you went into that residential home and said, where's the PBS plan? They would look at you and say, what PBS plan? Yeah. And this is what we're trying to work on, is making sure people that work with adults with learning disabilities know what PBS is and know what their role is. And hopefully that will reduce the need to call you out at 2 o'clock in the morning for.
That's my job. That's
Yeah, I'm sure that we won't sort of fix this problem anytime soon. But I'm really thank you for listening. And
it's not normal for someone to be upset just like that. It's not going to come from nothing.
And that's the thing, because I don't know the patient.
Yeah.
I would not. I'm happy to go with what the carer is telling me.
And as I was just saying, when somebody brings a patient to you, and you've got no other information, you're being set up.
Yeah.
You know, you've got a prescription pad.
Yeah.
I'm going to go to Sarah.
I think it highlights a bigger issue. I think it highlights a bigger issue of medications optimisation in the community and who manages that. Because I think the people that you're talking about are quite lucky because they've got an adult disability service to be referred to. But at 2 o'clock in the morning, you haven't got an adult disability service to send an email to for the vast majority of people that turn up in A&E.
And they might not be open to it.
And no, that's it. And the issue, and I think you mentioned in your presentation earlier, that the GP then finds out that the person's on this medication, and the GP doesn't know necessarily why or how long, and then they can go on that medication for years.
But you because that person could actually be with that GP for years.
Yes, exactly.
And actually that medication never changes.
Exactly. So why? So there's an issue of looking at medications optimisations in the community. And
so
who does that? Because we don't have a community pharmacist to do that.
The presentation, I wrote down a couple of things to just mention, and one of them was I work for the Quality and Patient Safety team, so our bread and butter is incident reports, and it would be really useful if you find a service user, and it is really difficult because it's the ones that we've got oversight of that we're going to have more ability to help. But if you find that you've got a service user that is being cared for within the service that is being over-medicated, if an incident came in, we notify the GPs and we ask for feedback, and we could facilitate a meeting just to get the word out there, really.
We just go away and do some research and find out what's going on.
Right.
But the GPs welcome the help.
They do, yeah. We have good responses. Yeah. We very rarely don't. I think we've had the one person we had who had epilepsy, and the medication's not changed, like I say, for going on nearly 20 years. The GP openly said he didn't have the experience, but then I know that I can, I suggest that he refers to neurology and I can contact, but but it's a good response, but it's just, you just wonder why it's not happened before, and why did they not know what to do, what did they know?
So I don't think we have the pharmacy support, we don't have a community pharmacist, we have community pharmacists that work in the chemist, but we don't have a community pharmacist that would actually be able to review those medications. And I don't think many of our GP surgeries are employing pharmacists to do the regular medications reviews, and I think that's where you've got a gap there, because people in the community aren't having their medications reviewed, often for years on end.
Well, the question was for Louisa Beth, who runs the letters. Do you look at medication as part of that process?
Yeah, yes, we do. We look at all the PRNs, even all the medication, the regular medications, and we review issues to do with STOMP, because they've been on the STOMP pathway. So we gather all that information and we feedback during the letter.
Good, yeah, that's good. What's the criteria to go on the STOMP pathway? Do you have to meet a certain criteria for it?
No, I just found something.
You have to basically, obviously, you have to be eligible for the learning disability and autism service, and be on psychotropic medication. That's.
Well, I mean, we have people that are on rescue medication if they've got epilepsy. Just sometimes because it just gives us oversight, and someone's not going to fall through net for us. And because you've got people prescribed rescue medication, and again they can be prescribed it for years, and the protocol says, oh, you give so much rescue medication, but really if someone's not had a seizure for 2 years or more, you should be ringing an ambulance.
Yeah.
You know, because actually that's unusual for that person. There might be something underlying, so that must be your first protocol. So if we put someone on the STOMP pathway for the rescue medication, that gives us some oversight, and we can have discussions with services, can't we?
And that's one of the ways that we have improved safety, is by stopping PRN medications that aren't being used. It makes no difference to the patient because they're not taking the medication anyway, but it decreases the risk of medication errors, and it decreases the risk of the medication being given inappropriate, particularly by unfamiliar or agency staff.
I've just seen Moira with a hand up at the back there.
Yeah, sorry, it's a bit of a silly question probably, but I just wondered, do you go out to GP practices? Do you, because they do have that, don't they? They have those open doors where they get all their the GPs together, and you can actually present what you're talking about. So it would raise the awareness of it. Do you do that at all?
I haven't done that for a couple of years now, but certainly I'm in contact with GPs fairly regularly, but that's a good idea for us to go round again.
Work large.
But it's cost effective because it gets, it raises the profile and gets people thinking, because in these days of resource shortages, people assume that nobody's interested and there's no point doing anything about it. So, and this is why we're taking time out today to come here. I imagine you don't often get so many clinicians that make the, carve the time out.
Yeah, it's really good, really good. Thank you. Any more questions? If not, we will close the session and just have a quick 2-minute break and then do the next session. Thank you very much. Okay, we'll start with session 3. This is by our old adult mental health team. We've got Rahul Bintade, Associate Specialist Older Adult Psychiatrist, Paul Corcoran, Community Psychiatric Nurse, and Sarah Morris, Consultant Psychiatrist. So they're going to talk to you about monitoring physical health in patients with dementia. So thank you very much.
Thank you. I'm Paul Corcoran, clinical nurse specialist in the older adult mental health team, also a nurse prescriber.
I'm Dr. Bintade, I'm the Associate Specialist in Psychiatry.
Dr. Morris, Consultant Psychiatrist.
So we are part of the older adult mental health team. There's about 10 of us. We primarily deal with people with dementia, referrals from GPs, care home liaison, diagnosis, post-diagnostic follow-up. We also deal in medications as well. So if you don't get the message about antipsychotics after these 2 sessions, there's something the matter with us, I think. So we're looking at antipsychotic monitoring in the older adult population. I know the question was asked down the back there. So before we get on to what we're doing, just some of the drivers behind why we monitor the side effects of these medications. So we're following guidelines from NICE and from the Maudsley prescribing guidelines in psychiatry for the monitoring of these drugs. These are not benign drugs, as you pointed out. There's no such thing as a completely clean medication that affects just the target receptors you want. It also has sort of systemic effects as well. So we're trying to, these drugs are designed for major psychosis, designed for schizophrenia, but we're talking about using them in older age population in dementia. But they do have knock-on effects on the metabolic system, including weight gain and diabetes, neurological symptoms such as akathisia, sort of restlessness and involuntary movements, also sedation on the neurological side, cardiovascular system with QT prolongation, and there is a risk of stroke and death. And on the endocrine system, things like plasma prolactin raised and thyroid dysfunction. And one of the kind of key reports that came out was back in 2009. There has been several more since. Was Banerjee's report, the use of antipsychotic medication in dementia, time for action, and Banerjee pointed out that these medications appear to be used far too often in dementia, and the potential benefits are possibly outweighed by the risks. So you've probably got a 1 in 5 hit rate. You know, 1 person in 5 will get the benefit that you seek. 4 out of 5 would probably get no benefit at all from the antipsychotic medications and just get the side effects. So he called for urgent action to reduce inappropriate prescribing. Noted that care home residents are disproportionately affected, and that's a concern because you know, sometimes people look for the you know, to deal with difficult behaviours. The quick solution might be a medication, which is not the answer and is often doing the person more damage. As I mentioned, there is increased risk of stroke in the elderly, falls, sedation and death. As pointed out in the previous presentation, we should only use antipsychotics when absolutely necessary and after non-drug approaches have been tried. So all the non-pharmacological stuff, all the environmental stuff, all the person-centred stuff, the biological stuff, all of that approach should be the first course of action, and only then, when they've been exhausted, should we consider low-dose antipsychotic if necessary. And then, if it is prescribed, that we should review the medication and aim to take it away, because as we heard, sometimes, you know, we can see these patients 10 years down the line still on the medication long after the problem has disappeared. So those are the drivers, and monitor for the side effects and document rationale. So we're going to talk about
so this is what we did, basically.
What we did.
So we decided to do an audit into people prescribed antipsychotics known to the older adult CMHT or previously known to the older adult CMHT. So we looked back over a 12-month period, there was 50 patients who'd been prescribed antipsychotics for any diagnosis of mental health illness. So that would be dementia alongside depression, anxiety, psychosis. We collected data on age, gender, where they were, whether they still were under our care or whether they were under the care of the GP, which antipsychotic had been prescribed, why that prescription had been commenced. I think I'm missing one off the bottom there.
Physical health monitoring.
The physical health monitoring requirements, which are then on the other side. So the Maudsley guidelines are the people that tell us what we should be looking at to make sure that someone is as well as they can be if they're needing these medications. So there's some blood tests that they need, some fairly routine standard ones, prolactin and CK, ECG, looking at those cardiac changes, weight, looking at those metabolic changes, and blood pressure as well. Am I pressing up?
Yeah, that one.
That one. So this is the data that we collected. I don't think anyone would be surprised by that age range of people that are under the care of the older adult mental health services, primarily above 70, still quite a high proportion of people over the age of 90, and then the gender, that's fairly standard. We see more women than men. There's thoughts on why that happens, women presenting to GPs to get referrals onto us, or potentially suffering more mental illnesses.
We live longer.
And we live longer, yes, that's right. This is where the patients were. So great, I think, that 60% of the people, that bottom part of the pie chart, are still in the community, and that fundamentally means still living in their own homes. We've got 16% of people from the hospital, inpatient, over the road, 4% in assisted living, so Grand Court Hill or Nova Maritime, and 20% in a care home on the island. And then a larger proportion were still under our care. 36% had been returned to GP care. This was the proportion of the antipsychotic prescribed. So again, for me, as the prescriber, risperidone is generally the one that we would choose. And so not that surprising that it was the highest proportion. I think really reassuring for me was that no one had been started on haloperidol, and a smattering of a few other choices, so quetiapine, olanzapine, aripiprazole, and then I think we do have some patients on depots, so things like paliperidone, so that's what's captured in the other 4% down there. These are the rationale for prescribing. So sorry for those of you that don't know what that little acronym means. That means the behavioural and psychological symptoms of dementia. Again, highest rate of the people that we were seeing. Don't think that that's that surprising. And then the other sort of functional illnesses that we also see, so psychosis, mood, delirium, and then other, which I think was anxiety disorders, if I remember correctly. So as an adjunct to antidepressant. And then this was how we'd done with those 50 patients with their physical health monitoring that they should have had done because they were all prescribed an antipsychotic. So the first 5 are sort of the standard blood tests. 66% is the highest number on that chart for anyone that can't see it. So not brilliant. And it gets less as you go down. So only just over a third of people were getting an ECG. 28% were having their weights done, 24% were having their blood pressure done, and then the more what might be considered unusual blood tests that you actually have to write on the form were 1 in 10 and 8% of people. So a long way to go to improve what we're doing.
So what we've done since we've got this data is that we've circulated the information to the GPs. We also have route into the GPs, and we have presented, not this data, but we've presented other data about Memory Clinic. And the next time I think we do that, we might also give them information on MACE. But we've sent out information to all the practice managers about the importance of monitoring people who are on and continue to be on these medications. Sometimes we do discharge people on low-dose risperidone. They may be in a care home, they may be in the community, and you know it's working for them. We're talking about 0.5 milligrams perhaps, or quetiapine 25 milligrams, but it's treating the symptoms without undue side effects. So, but we do advise the GP to, you know, at least 6 monthly, I think, is it, to monitor those data that we showed there. And our plan is now to re-audit again. So that the first group of numbers there was a kind of a snapshot of where we were. Now that we know what we should be doing, we hope that the new set of data will show that we'll have increased a lot of them, and that maybe that they'll all kind of level out a bit more as well. So we are making a concerted effort to, you know, it's on our sort of MDT meeting. If anyone's prescribed a new antipsychotic, it's noted. Have you done the requisite screening and monitoring? And thankfully we have agreement with Jo Murphy in Oberlins to use her clinic, and we can book people in there to get the whole lot done. And she's very good about that. So
you've upskilled yourselves as well as nursing, that you know more of the team can take blood, so we're not as reliant on the GPs to ask for that information. We can actually arrange it and do it all ourselves and get the tests that we want, so that it's much more in-house than it perhaps once was.
And I think one of the things we do, like when we write letters to the GPs, every single time when we have written an antipsychotic, we usually advise these need physical health monitoring requirement as per these guidelines. We are in the process of developing our own guidelines as well, based on the UK, but that's not on. We need to finish our audit first before we can say we're going to do that.
And we're planning to re-audit now. Basically, it's due.
It'd be really useful to hear that when you've done it after a little while, to see what your results are, and
we can compare
maybe
the
have
two.
you back in a couple of years or something and just see where you're up to.
Next
It'd be
year.
good. Next year,
Observationally, I think they have definitely got better with seeing more prolactins and more CKs when we look at the bloods, when we're getting referrals in, which is the baseline, which is what we need before we start prescribing potentially.
We're also seeing more ECGs.
Yeah, and again, the nurses have upskilled themselves with those as well, so if we need one, it's easier to access one. We don't necessarily have to ask the GP. The team can do it themselves at the Oberlins, and then we get to see it, which was the other issue sometimes, is if the GP's doing it, our eyes don't get to physically see the tracing itself.
I wondered if Vanessa, because you have a lot, obviously, with the care and nursing homes, do they do like annual reviews of medications as part of, is that part of your inspection?
They do, the GPs do 3 monthly reviews.
3 monthly?
Yeah, but they don't always take place.
Right.
A lot of it is due to cost, obviously.
Mm.
You know,
Because they've got to pay for it,
they get home visits, you know, and if they don't think their medication's going to change, and often their relatives don't want their medications reviewed.
So how can we challenge that then with the cost thing?
So what we started at the moment is doing an in-house thing. So our 3 wards, we have a spreadsheet of all the patients who have ECGs, bloods, everything. So they are not part of the audit, to be honest, but the nurses over there are keeping an eye on those. And as we get better data, we will then roll it out to the care homes and say, this is what we need to do. At the moment, we are just targeting the GP. We are not targeted care homes. We will do that. We have told them about it, but you know, the cost factor is something which we cannot do anything about, to be honest.
But I think we have tried to do something about it by the fact that we are now able to do our own bloods and our own ECG, and if we're obviously really concerned that that step needs to take place and it's not happening because of a cost thing, then we can have that discussion about whether it does need to be done.
I suppose it's about capturing the people that are now not under your team.
And
isn't it? Yes,
that's the difficulty.
It's the community bit, isn't it? Yeah, going back to that. Is that, I've started asking you questions, but is that at the end of your presentation? Oh, thank you very much. Have you got any questions from the audience?
With Rio coming in, is there a way of capturing that data on through Rio? Obviously with the tests coming in, and
we'll be using Maxims, not Rio, in community and mental health.
Okay.
So that'll be our new EPR. I think so. I've been doing some of the testing, and there's scope to put in all of those tests in.
Yeah, because I've only been here 4 weeks, but I worked some mental health board before I came here. We had something called Care Director, and you can actually pull up the audits from there. So obviously when people are getting the health action plans or the ECGs, for example, it'll pull through when they last had one, and if there's any abnormalities, just.
Yeah. Well, I think I looked at the Maxims last week as well. It is a bit clunky, but it is better than in drawing up information. So as we know better, we'll probably answer that question. Yeah. But I think Paul has had a lot of input with them. We have talked about what we need in terms of testing and ECG reports and everything. So hopefully they have taken that on board.
Yeah. The part of the testing yesterday was we were showing how you can pull data from the system, and it looked, like it can do quite a bit, but I think we've yet to see how it works in practice.
Will the systems talk to each other across? So, like, if I have someone in my service in learning disabilities that's got a mental health problem, will I be able to get that data as well, or will that be something I have to link with your team?
We'll have Rio Viewer. We can look. We'll be able to see into Rio, but we can't make any changes on it. I'm not sure how it works the other way. I don't think so. Hey?
For information to be shared where
both ways.
There'll be a Maxims viewer from Rio.
Yeah. So, sorry, I'm still learning the Guernsey way. So.
Yeah. Takes a while.
I think all the new EPR stuff is a bit like we don't really quite know, do we, what it's going to be careful of doing yet. But a while ago there was like talk about that you would be able to see that there's been involvement, but you won't be able to see exactly what it was. So you'd have to get in touch with like the person that is their kind of link worker or whatever. So
obviously work holistically, you need to be able to see what's going on for all of what
ideally it would have been one system, but
I believe that if you're on Rio, you don't have a reason to look into Maxims.
In our discussions about antipsychotic prescribing and deprescribing, we have also found a tool with Slaughter and Maudsley, which looks at antipsychotic monitoring. We have yet to adapt it because we are still doing audit. But I have the form with us. We're looking at if that can also be put it on Maxims, we can still do our antipsychotic monitoring, but I cannot guarantee that passes across to the GPs or to the hospital.
Yeah.
Do you get the same pushback from patients and relatives that they've been to the GP and they've on X, Y, and Z drug and they just want to go off that, or do you find it because with the last group it's
very variable, honestly.
Yeah.
Because some families don't really like patients on drug medication. and they will push for it to be taken away.
Yeah.
Some are neutral, they will take our advice, and there is a group of people who will say, why are you stopping this? This has worked for the last 10 years.
Yeah.
So.
Yeah.
Do you have any kind of buy-in or interest from other areas of mental health? Because obviously you are far from the only area that prescribes antipsychotics. Generally working age adults prescribe much higher doses.
So what we plan is present this audit in the doctor's team at some point, and then obviously we can ask if anybody else is interested in doing a collateral one.
Because I think, you know, as you know, in adult age psychiatry, you're prescribing much higher doses, and the metabolic kind of side effects are going to be much more pronounced. Cardiac issues, weight gain.
I think some the longer term teams probably have it fairly well in hand.
Yes.
But the shorter term teams where they might start and discharge back to GP, cost is a massive barrier for all ages, I think, in terms of, I'm not, I think you could have a blood pressure on. You know, they don't, do they? People often don't.
No, they don't.
Do that. So,
no, that's a barrier.
that'd be really interesting if more services provided to it.
Which is exactly why we have this kind of event, so people will look at it and think, actually, that would be really relevant for my service. So, we hope that that's what we get from it.
Because I'm kind of thinking if we've had this audit for learning disabilities, that might link into STOMP work, and it might pick holes and see where people are going unregulated or unmanaged.
Yeah, we have registered the audit with the audit office, so I'm happy surely to share the audit tool and everything with you guys once we finish the re-audit, to be honest.
Can I ask as well, because it's part of our wider team, do you go through the audit? Yeah, brilliant. Just make sure you do that. Any other questions? Lovely. Well, thank you so much for speaking to us. Thank you. So I think you'll all agree we've had a real range of speakers, really interesting. I've learnt loads actually. So, and you can see actually the relevance of different groups' work is like, it could link in, couldn't it? And you could really share a lot of good stuff. So that's what it's all about, and getting to understand what people are doing, all the great work, because you just don't hear about it, do you? One thing before I close is I've been told to plug, and I'm going to it actually. It's the virtual patient safety conference on the 3rd of October, 9:15 to 3:30. It's on Teams. It's bookable on My Learning, and in the STOMP presentation you were talking about Oliver McGowan and the case he died in of medication. His mother's actually speaking at that conference, so book on My Learning and join us. Yeah.
And it's okay if you can't join for the whole day.
Yeah, you can just drop in and out. Yeah, of course. On there, because Joe's been organising it, the bios of the speakers are on there, aren't they? So can you remember
Any questions? Just send me an email.
Can you remember what the other speakers are offhand?
We've got David Shevings, who's talking about child and baby attachment theories. Got Baroness Gilbert Keithley talking about co-production. Who else have we got?
Got Ron Daniels from Sepsis Trust.
Sepsis, paediatric sepsis.
Yeah.
Really. Got Darren Evans from Jersey. She's talking about the work she does over in Guernsey as well. So it should be really, really good speakers.
Brilliant. Lovely. Oh, well, thanks.
Yes.
Professor Sanders, I'm not remembering this anyway, is in front of me. To talk about butterfly effects in leadership. So all of the time slots are out, so if you can't attend all of it, you can go ahead and see.
Thanks, Claire. Well, thanks all for coming. We'll see you on the 9th of December as the next session, so see you then. Thanks.